down the dosage of insulin. And in both the cases, I think, even though they are quite young, especially the second case, she is just 13 plus 2, 15 years. The first one is 18 plus 2, 20 years. So both of them, the family should be trained in such a way that these are going to be girls, women in the reproductive age group, raise a family, and then the pre-pregnancy council should be started being a girl child. That is my point of view. So at this stage, I think the workup has been there. Probably the workup of Modi, I would have entertained even in the first case because of the age of onset. I think you have done it in the second case because whenever you have the opportunity to see the case, I think I would again like to remind the audience that these cases have not been followed up right from the beginning till the presentation by both of them. It is in between they have had the exposure and they have captured the data and how we would have reacted had we seen the patient at these stages of the disease with the available investigations. Yes, I think the workup is complete, the message is complete, but from the point of management, absolutely, I think your clinical knowledge that hyperglycemia has to be controlled, the focus has to be on insulin in both the cases.
In fact, I have a few cases, about 10 to 12 cases, which are adult onset. In the sense, adult onset is around 30, 25, like that. Most of them come into the back, right? And then they had a very good C-peptide all through. In fact, almost about 5-6 times every year I used to do that. But they can never got under control with oral drugs, including pioglitazone, such sensitizer. They did not. They required a combination of insulin twice a day, because they are not type 1 diabetes, basically GAD negative only. Everyone is GAD negative. So we used to have two injection doses plus all the oral drugs. Only then we were able to control. It is very difficult to explain that. In spite of having a very good C-peptide, they don't come under good control with oral drugs.
In fact, Dr. Morgan Center, along with somebody from Norway, last year I think, remember, they have come out with 6 types of presentation in Indian phenotype. Yeah, what do you call that? Clustering of. So there are Indian phenotype is very, very heterogeneous. I think we cannot compare with the Caucasian population and say ours is very different.
So here also you cannot classify them as syndrome of defective insulin secretion because both the C-peptide are good enough. I think it calls for. I think before we proceed to the third case, if you allow maybe a couple of comments from the audience. We have senior diabetologist physicians here. Our chief guest is there. Yeah, anybody from the back who want to have a question? Maybe 2 or 3 questions before we go on to the.
Apart from GADA, there are other prognostic markers like.
1 minute, I think he is making a.
Mike.
So apart from GADA, to
please introduce yourself. Please introduce yourself.
I am Dr. Gnanasekaran.
Yes, I know. Yeah, please go ahead.
Apart from GADA to diagnose type 1 diabetes, what about islet antigen 2? There is another marker, and zinc transporter 8 marker. We could have done that so that from the back of the arm we can arrive at the diagnosis.
Available, sir. It is expensive. It is not widely available. 90% of the time we can go with GAD, but sequential GAD we have done. GAD costs 1,000 rupees if you do it in MGR Medical University, whereas the zinc transporter, I think it costs about 10,000. The islet cell, IIA and all costs about 4-5,000. I went with the cheapest one. We did it sequentially for both the patient. It was negative. So for practical purpose, GAD alone will do.
And Gauri, out of the 3 you mentioned, which one persists longer? That is also very important because both the cases you have seen GAD is the only
persists longer,
whereas the other antibodies can disappear very early.
Oh, okay.
Any other question or comment before we go on to the other cases? Sir, yes, please.
Sir, HbA1c 3 months once we'll do, sir, like that for GAD, and they said C-peptide. What is the interval for follow-up and all, sir?
No, that is a beautiful question. As I have known of, there is no protocol. But in this particular patient, with the index of suspicion of a progressive nature of the beta cell dysfunction like type 1 being very high, so let us not stay put with just one value of C-peptide. Down the line, when you have resistance to control, try to control and then repeat the C-peptide so that you can document this patient had an initial, probably a good, robust C-peptide response. Now it has come down. Now you know the diagnosis and how to go about it. It's a beautiful question. I think it's your clinical discretion.
Repeated after 1 year or what interval?
No, that's your clinical discretion.
No, once you get a near normal glycemia, probably you can repeat a C-peptide at that point of time, because initially when the patient is having glucotoxicity, your beta cell function may not be that very apt, so you may have a very low C-peptide value. So once you start an insulin, whatever is the type of diabetes, once you get a near normal glycemia, then that is the time you will get a better idea if you repeat it. It may be even after a month, it may be even after 3 months, it's up to us.
You may ask why we did GAD antibody twice. There is a recommendation from, I think, Norway or Canadian guidelines, where they say like if you are going to diagnose only based on GAD, so you repeat it in another lab to see what has happened. So that is what we did.
Another lab.
If you are going to diagnose based on 2 or 3 antibodies, it is better. But repeating means GAD twice, it costs 2,000 rupees. If you want to ask another antibody, it is going to cost you 5,000 rupees. So that's what.
So economically it is good.
Yeah, I think when we approach a patient, that's what we do in practice. The clinical knowledge is there, our experience is there, and the patient is there. So we have to balance everything and then order for the investigations for you to have a working diagnosis, a substantiated diagnosis. And then a comment from Velu before we go to the third.
Yes,
yes, Velu.
as pointed out by Dr. GVK, he has tried most of the tablets along with the twice day insulin also. Such patients, I have added imiglamin that showed very remarkable improvement. I have used imiglamin in more than 400 patients. I have come across significant improvement with reference to fasting postprandial as well as A1C, and the insulin dosage has come down drastically also. That is imiglamin. And I do come across obese patients with the type 1. On the background of patients, both the parents are type 2. And this patient type 1, after started giving insulin, that patient tend to develop obesity also. But GAD positive, C-peptide very low, both in the fasting as well as post-meal. And yet another patient, next is, that is, you told, do C-peptide initially, repeat after some time. One particular doctor did C-peptide initially low, started on insulin. After 6 months, C-peptide level came up. So he stopped insulin. Automatically patient started developing same hyperglycemic symptoms. So that patient came to me, I told, initially C-peptide low, after giving insulin, there is still some, beta cells are viable, this can secrete, the so-called honeymoon phase. There will be temporary improvement, fasting and postprandial. This will remain for a short period of time. After that, automatically, our aim is to preserve such beta cells also. C-peptide positive type 1 in the long run. Definitely retinopathy, neuropathy and nephropathy incidence are less. That's what we normally convey to our patients.
I think you have brought in a very important point, the honeymoon phase. So honeymoon phase can be up to 2 years, I think, maximum 2 years, not more than that. So I think till then you have to be very careful, keep on, as you said, that keep on checking the C-peptide, but continue to be on insulin to just overcome the honeymoon period.
I think these two cases, as has been nicely exemplified by additional inputs from Dr. Shanmuga Velu. Yes, there are two aspects to the approaching this patient. One is your pursuit, your endeavor to arrive at a etiological diagnosis. So we have done from the clinical history, from the presentation, from the available investigations you have. The second is, whatever be the label, just because the C-peptide is positive, do not ignore the glycemia, the HbA1c. In other words, treatment. I think when it comes to treatment, the very fact that the C-peptide is positive gives the clinician a cushion to think about at this stage about introducing the OHAs, like for example your metformin, imiglamin. Yes, I totally agree with you. So it gives you a scope. So there are two aspects of management of this. One is a diagnosis, your attempts to arrive at a diagnosis. The second is your attempt to control the glycemia. I think that's what the exercise we have learned, and this is a good I think always worthwhile remembering the message of this presentation is being caught up in this. So when you have a young diabetic, then look for these things. The presence or absence of autoimmunity, and then the level of the beta cell insulin reserve. I think that is a message that you have. Other things, I think all of you have adequate experience. Before wasting time, I think shall we go to the next case?
Yes, sir. So next case is, so here this is actually an even more interesting case. You can see a 31-year-old male having a BMI of 30 I think Dr. Gauri has written Kattai there. You can ask him after the lunch period what is the Kattai means. So, having a BMI of 30, age of the patient is 31. Initially, he was seen. See, this actually happened 2 years back, in 2021. He came to us somewhere in 2023. So, 2 years before the presentation to us, he went to a senior diabetologist where, looking at the phenotype, OHA was started. And initially, patient's blood sugar came under control, but once again it went up, drug was escalated there. So ultimately, by the time he met us, what happens is that he was on 5 oral drugs, including SGLT2 inhibitors, metformin, sulfonylurea, AGIs, and DPP4 inhibitor, as well as SGLT2 inhibitor was there. So this is his history. Family history, if you look at it, his father has diabetes for the past 10 years, but now the presenting complaint is that he has balanoposthitis. And look into the blood sugar level. Fasting is more, very, very high, 190, postprandial is 342, and HbA1c is 9.2. So this is the presentation. A typical type 2 diabetic individual on 5 oral drugs, not under control, with an infection. This is the presentation. You want to add anything to this?
So, sir, my fundamental question is, like, he has a balanoposthitis, severe balanoposthitis. So, should I ask him to undergo surgery because he has insulin resistance? So, once his treatment gets controlled, probably his sugar may also...
Before subjecting to surgery, I will withdraw SGLT2 inhibitors.
Sir, okay,
why is on
obviously.
SGLT2 inhibitors when he has severe balanoposthitis?
SGLT2 are withdrawn. So, will I be waiting for the infection to control before putting him on insulin because he is reluctant? Or should we prepare him by giving insulin, treating him, because anyhow it will not get treated because he has such an underlying infection. What should be my approach? So should I ask him to get the infection treated, or is the glycemic control important at this point of time?
Glycemic control is very important. I think I will withdraw SGLT2 inhibitors, give insulin, control the hyperglycemia.
But he is suffering over there.
No, Gauri, you can see that. No, as Professor Madhavan has said, that you have to withdraw SGLT inhibitor. But believe it that it's 9-point HbA1c balanoposthitis. I think one of the indications for insulin therapy, even in type 2 diabetes, is this infections actually. So I think this is a case where before even diagnosing whether it's a type 2, type 1 or whatever it may be, I think this situation warrants a small dose of insulin. So the sugars will control better. Maybe balanoposthitis may improve even before deciding about the circumcision.
So having started him on insulin,
no, the issue is that 5 oral drugs did not control the diabetes.
Yes.
It was
This
added
is a very
sir.
How many years of diabetes by then?
By this time and presentation, 2 years of diabetes.
For 2 years of diabetes requiring 5 drugs and then sugar not under control, it will give a lot of thinking about the diagnosis of this patient.
But at this KVT always used the word red herring. Some of you have been used to. So here the red herring is the BMI. So in this case, of course, Vijay said, yeah, there's a practical approach, control the glycemia. I think if the clinician who sees this patient, he or she is justified in making a diagnosis of obese type 2 diabetic subject. So even though sequentially it has been added, maybe that has been neglected, that the positive response to multiple OHs has not been there, but you are justified. I think it's a question of discretion, because you would like to introduce both a GLP-1 receptor agonist as well as an SGLT2 as early as possible in this patient to facilitate reintroducing the SGLT2, certainly withdraw, achieve the glycemic control with insulin, have the circumcision, and then the earliest opportunity, because you would like him to lose weight. Because now the data have emerged that, be it obese or non-obese, first few years, 6 years of diabetes, huge weight loss, 5%, 10%, 15% can reverse diabetes. So these are all the messages, may not be relevant in this case, may not be achievable in this case. So with this, I think the aim will be to control the blood sugar level, and then at the earliest opportunity, introduce molecules and reinforce lifestyle in such a way that along with your glycemic control, you achieve a tangible weight loss, which is now quantified. So weight loss of something like about 10 to 15%, if you achieve it, then you can probably even reverse diabetes.
But Venki, in this case, with 5 drugs, his control is not good. What's the point in continuing the oral agents now?
Wait. See, in a similar forum, I tell you, lifestyle modification and weight plays a lot of role. I think we tend to ignore that. So At this stage, I do not know about the further progress of this patient. With this presentation, my endeavor will be to push him to lose weight. Maybe he is about 5'8", probably he'll be around, say around 78 or so. So, or even more than that, 80, 82. The BMI is 30. So if he is going to be 5'8", 170 centimeters, his ideal body weight will be about 67 to 72. So there is a cause for losing about 10% of the weight at the earliest opportunity. I'm just giving an example. So once you do that, maybe the OHs which have been refractory to this at this time may start having some response.
I totally agree with you that he has to lose weight, but at this stage, you introduce insulin or not introduce insulin?
Obviously. I would want to introduce both the molecules. To facilitate me introducing the SGLT2, we need to have that disturbing factor of phimosis. So have the circumcision done.
In fact,
facilitate that, yeah.
In fact, as Professor Venkatraman was telling, if you lose really 10% of the weight at this stage, 2 years of diabetes, I think there will be a remission in diabetes is possible. If it's a type 2 diabetic, and 2 years and remission.
Vijay, can we talk about remission in a person who has A1C of 9.2
no,
with 5 oral agents?
No, sir. The power of LSM. Hopefully, I'm not talking about this patient, but in general, if they lose 10% of weight, if it's a type 2 diabetic, the remission is possible.
At any stage of glycemia, at any spectrum of glycemia?
No. Initially, we need to control and then we can withdraw that. 10% weight reduction without drugs is the most important thing.
I agree with you, Dr. Vijay Kumar, but in this index case, do you think we can talk about remission? I don't know.
Not in this situation. No, I'm talking about not this situation because Professor Venkatraman raised the issue of 10% of the weight reduction that can induce remission. That's what I'm telling. Not in this. In fact, I said you start insulin, control the diabetes, infection may subside. That's what I said.
Yes, that was actually done for this patient. This patient was actually subjected to circumcision with some antibiotics. Insulin was started, and as Professor Madhavan sir said, SGLT2 inhibitor was temporarily withdrawn, and you can see he was started on insulin. But what happened is that his insulin requirement was very, very high here. It went up to even 1.5 units per kg, and again he was continued on metformin with a DPP4 inhibitor as well as a low dose sulfonylurea was continued. But in spite of all these drugs, blood sugar did not come down. So obviously after few months, what happened? SGLT2 inhibitor was actually reintroduced after a period of 6 months, and then after that patient had good control. See, you can see from 9 point something to it came up to somewhere around 7.2, had a good control. So everything was going smoothly so far. You have any doubts to clarify here?
Sir, I have one doubt. Why was he requiring about 1.5 units per kg, sir? So
very high.
BMI 30, but a huge requirement of insulin with metformin and sulfonylurea, and even only with SGLT it was getting controlled. So it is usual for us to expect this much amount of insulin requirement.
In this context, can we think about FCPD in this particular case? 30 years.
No, with this
because obese. FCPD is never, very rarely very obese.
But nowadays due to lifestyle, you even have a type 1 diabetic having obese.
No, pancreatic diabetes are usually
BMI will
very,
always
very
be less
thin.
than 20.
No, only with treatment they may put on weight with insulin and other things. But as a case, a pancreatic diabetes is never obese.
In fact, it is well known that pancreatic diabetic subjects do not gain weight even with insulin. And of course, the requirement of insulin will be very high, but I don't think
correct.
so.
That's the point.
It doesn't warrant a consideration at all. Of course,
Yes,
we do
yes.
always a ultrasound, etc. But regarding Gauri's question about the SGLT2, normal teaching is when you introduce SGLT2 inhibitor and somebody who is already on insulin, reduce the insulin dose by 20%. But in clinical situation, we have seen that the reduction in insulin dose is far much more favorable with the introduction of these molecules. Few things are there. Loss of adipose tissue, especially the loss of central adipose tissue, and much more, the much hypothesized level of action. They act at the level of the central autonomic nervous system. The autonomic flow is reduced when you have an SGLT2 inhibitor. Maybe more than one reasons, and maybe reasons which we have not yet identified. So in this particular case, the reintroduction of SGLT2 has been rewarding. Number one, the HbA1c is touching towards the target maybe for the first time in the last few years. And number two, I think you did mention that the insulin requirement also is coming down. So these are the two clinical endpoints which the clinician should be happy. Now we can proceed.
So I'll just quickly go through what happened to this patient. So everything was going smoothly for this patient, and even engagement was fixed for this patient. But everything was going smoothly till then. What happened is that 2 days before his engagement, what happened? He developed vomiting, and he reported to a nearby hospital for that. There they evaluated him, and eventually, looking at the condition, they even did a ABG for him, and we can see that he was in severe metabolic acidosis. His pH was only 6. Bicarbonate was something somewhere around 5, single digit. So this was the scenario. Had a metabolic acidosis, shifted to another hospital for again intensive care. But at that point of time, if you look into the HbA1c, it was still under control. It was still 7.3. On insulin, on oral drugs, including SGLT2 inhibitors. And this is where I just wanted to ask from the experts here. A patient whom we considered as type 2 diabetic, on insulin, on other oral drugs, fairly under good control. Obviously, you can see the blood sugar is under good control. There is no foci of infection here. So to push a patient to diabetic ketoacidosis, you need some kind of a precipitating factor. Obviously betrothal will not be a precipitating factor.
How much of
betrothal? Yeah.
How much of insulin was reduced when SGLT was reintroduced?
When SGLT2 was reintroduced, I'll just tell you, with the same dose of, with the reduced dose of insulin, he was maintaining so long, so good.
It is well known that when you reduce insulin in a patient getting SGLT2 inhibitors, they can go into euglycemic ketoacidosis. That is why we always caution, don't drastically reduce the dose of insulin.
But these things can...
No, sir, even with SGLT2 inhibitor, earlier he was taking 40 units of prandial insulin, now it has come down to 32 or 30. That is what warranted.
But
because
he is not withdrawn during this time. No, the insulin was not
withdrawn. He was
withdrawn.
doing well with SGLT2 inhibitor and basal bolus therapy. For 6 months he was doing well with the 30 units of prandial insulin 3 times a day and 40 units of basal insulin. That was the amount of insulin he was requiring, about 130 or so. So we were able to reduce 30 units with SGLT.
The question here is whether it is euglycemic ketoacidosis or something else.
So
obviously,
a clinical recap of this patient is a obese diabetic warranting a label of type 2 diabetes mellitus, a family history of diabetes, presence with hyperglycemia and multiple OHs with poor response, had phimosis, had an intervention in the form of circumcision, SGLT2 reintroduced on top of insulin therapy, which was introduced to control the glycemia. The insulin requirement came down as expected, and the HbA1c started approaching towards the target value. At this point of time, without a provocation, he has an episode of diabetic ketoacidosis, warranting the clinician to undertake the exercise of questioning the labeling that has been given to this patient. Am I right, Gauri?
Yeah, see, in fact, the requirement of insulin is so high, sir. Actually, with oral drugs itself, the insulin requirement is so high that warrants about thinking about another diagnosis. Definitely.
Correct, and with 5 oral drugs not under control
I want to ask
initially.
you one thing. Because this patient had a DKA, now we are becoming retrospectively.
No, sir. If you
without
remember,
the DKA, will you have a rethink on the diagnosis? I don't think I would have.
No. The thing is that here, the Dr. Professor Madhavan has said probably euglycemic ketoacidosis. Yes, I agree with him. But when somebody is still on insulin, developing euglycemic ketoacidosis, is it because of SGLT? It's a big question mark. No. That's the most important thing. He was already taking up to 100 units plus even now.
Yes, sir.
Did he miss the insulin dose during that betrothal?
Sir, that is the climax here. So that is what
we know that SGLT2 inhibitors are off-label for type 1 diabetes. So somebody puts SGLT in a type 1 diabetic and then reduces drastically the insulin.
Obviously, then they will land up in trouble. But
yes.
No. Sir, remember, sir, in the first slide when he put it, I said, in spite of 5 oral drugs, 9.2 HbA1c, we should not think only about type 2 diabetes, something else we need to think about that. Remember my state?
Yes, sir. Yes, sir.
I think in diabetes, the way the phenotype of an individual is presenting has been given a lot of importance, quite justifiably, that it becomes a disappointing. For example, had this patient presented to me at the age of 31 with a BMI of 22, with a high blood sugar level, LADA will be at the back of my mind. But with a BMI of 30, with a family history of diabetes mellitus, certainly type 2. Now, with so much of OHS being on board, the requirement being on board, as Professor Madhavan rightly anticipated, yes, should we call for a rethinking about the diagnosis? Yes, after this episode of DKA. In other words, in clinical medicine, you're always in for surprises. A seemingly a type 2 diabetic patient with obesity, with certain amount of hyperglycemia, and responding to multiple OHs and some insulin on board, has an episode of DKA. It calls for rethinking on the diagnosis. So anything can go wrong, will go wrong.
Murphy's Law says, anything that can go wrong will go wrong. Only when you are hungry, the meeting will get extended. Only when things happen like this, his betrothal was scheduled, he was landing up with the DKA. Only when you want to attend the clinical meeting, you will have some 5 patients sitting outside your room. So things will go wrong at any cost. So in this patient, when his betrothal was scheduled, he was money crunched. So he was missing his long-acting insulin because he was not able to purchase it that time, costing some few bucks. So he was not able to afford. Second thing which happened was, he used to always give, not in the thighs or in his abdomen, he used to always get his insulin administered in the back for whatever reason, that is what he feels comfortable. Now before this episode, his insulin pen has broken. So with this broken insulin pen, he was administering, not knowing that the inside is made of glass and that can get break. So he's thinking that insulin is getting administered, but there is a crack through which the insulin was getting leaked. So because of that, he missed only 8 doses of insulin, and basal insulin he has stopped, and he's on SGLT2 inhibitor. So this predisposed him for this euglycemic ketosis, and with the pH 6, he was hydrated, and whatever was treatment, he got treated, and he attended his betrothal also, and he is doing now well. So this is the message and during admission, during discharge, his GAD was positive and C-peptide is negative. So if you see this patient from the first, like we didn't do a GAD antibody, but C-peptide was normal. So we thought that he will do well, but that was not happening. So as we said, the point that needs to be reiterated is, keep doing sequential C-peptide to see what is happening to our patient. Just don't get satisfied with one C-peptide. Rather, if you would have thought about doing C-peptide when he was recurring, as Vijay Kumar sir was telling, like as we thought at that point of time when he was taking SGLT2 inhibitor with such a huge dose of insulin, if he had thought about alternative diagnosis, he wouldn't have landed up with this euglycemic ketosis. That is the message that we got from this patient.
Is a LADA or?
So probably it could be a LADA.
What label you are giving?
LADA turning out to be a type 1, sir.
It is LADA, but what happened, he was actually started on sulfonylurea also, that would have beaten up the beta cells. So gradually what happened is that he did not have any insulin reserve, and unfortunately for him, he stopped his insulin dose, and he was simultaneously on a SGLT2 inhibitor. So one part insulin, lack of insulin played a part here. Again, SGLT2 inhibitor also pushed him for a euglycemic ketosis.
Probably.
Actually, yeah. See, if you look at the sequence, temporal sequence of what's happening in the pancreas with respect to type 1 or LADA, the autoimmunity starts, and then the autoimmunity goes up, then the beta cells are destroyed, and hyperglycemia. Here, I think the GAD antibodies were not looked up because the clinician cannot be blamed. I don't think you will would like to do a GAD antibody positive in somebody with a BMI of 30 with a family history of diabetes mellitus. Certainly you accept a diagnosis. So retrospectively, again, as Professor Madhavan said, when he is resistant to treatment with 5 OHs warranting insulin, maybe at that stage, again that BMI would have precluded the clinician from entertaining a diagnosis of a type 1 in this particular case. But of course the clinching was the betrothal and subsequent events, like we say, the many a slip between the cup and the lip. So many things have been happening. The syringe is broken, he has missed his long-acting insulin, he is on a SGLT2 inhibitor, even though we can call it as euglycemic or certainly a frank hyperglycemic diabetic ketoacidosis, still it calls for revision of the diagnosis which has been established. So we come to the end of the session.
No, the caveat is that, the LADA, who is an obese one, the caveat.
Exactly. So
that is what is most important.
When you look at the textbook, presentation 30 to 40, lean, probably no family history of diabetes mellitus, GAD antibody positive or at that point of negative. Sometimes GAD will be positive, the C-peptide will be good. So, in the presence of autoimmunity, there are some people who say that you are justified in continuing the OHAs. But let us take it in the reverse way. If you had started some patient on OHA in a suspected LADA, GAD positive, with the C-peptide subsequently becoming negative, retrospectively you need not feel guilty because you are justified. At that point of time, when you had a diagnosis, you probably thought it was a lean type 2 diabetic subject becoming a LADA. I think brilliant cases worked out by both of them. So I hope all of you enjoyed these presentations because these are clear-cut, real cases. I think many aspects were not comfortable for the discussion point of view, from the point of view of labeling or otherwise, but this is what has happened in the clinical scenario, and this is what probably we could have done, or probably something much more, had we seen that patient. I think that was the purpose of this exercise, and I think both Professor Madhavan and GVK, thank you so much for joining in this.
No, sir, thanks for you, number one, and number two, these two guys. Really, you gave us food for thought. No, it's ambiguous cases, it's not straightforward cases.
Dr.
And this is
Dhanmitra,
the beauty of
Natarajan and
discussion.
Parandaman, please excuse us. I think we have exceeded the time limit, not by just 5 minutes, but 30 minutes.
Just one point I wanted.
Thank you so much.
Thank you.
Thank you very much. Let's give them another big round of applause. Okay. We will now adjourn for lunch. Thank you for joining us till now. Please stay tuned because we have some really nice talks in the afternoon and we would love to have you all with us again here in this hall at 2:15. Lunch is being served on the mezzanine floor in Varahari Halls 1.
How do I move the slides? So, good afternoon, everyone. Is it open? With what is special in elderly? How an elderly patient is different from the other age group. In Western setup, if we say elderly is more than 75, but we can definitely say it is more than 65 is elderly, especially when the patient has comorbids, significant comorbids above 60 years. We should be doubly careful before starting specific pharmacotherapy. We should have an idea about what drug the patient has to receive. So what is the significance of elderly is, we all know there is higher risk of various complications. The most important I will put as either hypoglycemia or higher rates of death from hyperglycemic crisis, especially DKA and HHS. So this is what all other things we know. There is a higher incidence of major lower extremity amputations, MI, visual impairments, all will have a definite role in specific targets for therapy. Specific consideration, if you see in clinical practice, how elderly is different. There are two different types. Either he's a high functioning and medically stable person who can perform self-care, may or may not need a caregiver. That is the first group. That first group is easy to manage. For others who are unable to follow instructions and manage their own medications, it's a tricky management. It will be, you should be very careful about using medications, which can especially cause complications and hypoglycemia. To add to that functional disability in the second group, there is a term which is geriatric syndromes, we call it. In that, the primary we can say is dementia, cognitive dysfunction. With polypharmacy, you can see every patient, elderly, they will use their own medications, they will not listen to us. Because of various CNS issues, they will not be willing to listen to us. And the last one is urinary incontinence. This urinary incontinence not related to diabetes is also seen because of prostate and other issues. So what is the challenge? So young patient and middle-aged till 65, there is no issues about whether the patient is going for a new illness or acute illness. And the next important thing is there is a frequent change in overall health. The patient is not stable always to have a fixed dose of whatever drug you want to give. So you should educate the patient about this. If there is a major illness or there is a change in health, what is to be done to the patient? The family has to be educated. This frequent change means the most important thing is hypoglycemia. Sometimes hyperglycemia, which can affect various parts of the basal ganglia, extrapyramidal symptom. This will lead to decline in the cognitive status. Further worsening is physical disability. That's what is the elderly, a challenge in any elderly patient. To practically consider what I should focus on diabetes in elderly. We have discussed everything. So what is most important among this is we can put as hypoglycemia risk. This we all know, not alone elderly, in young also. The problem is in elderly is it goes unaware. The patient may not recognize symptom, we all know that. The last important is very valid point. When the patient is above 80 years, there is a slide from my side where if you feel that the patient is not going to live longer, don't have a good glycemic goal setting. That is very important. Don't try to aggressively control sugars if you feel that the patient's life expectancy is low. So the guidelines, various guidelines are there. I am not going to bore you with. It's always theory is always boring. With clinical aspect is always interesting to have a discussion. But all my talk will be based on this. What are the recommendations? And the last slide is always a clinical slide. What I feel should be given to the patient. In elderly, what is the treatment we have to follow? So various guidelines are there. Each guideline has different set of scenarios where what is to be followed. Guidelines are important because evidence-based medicine, without evidence-based medicine, we cannot blindly do any treatment. So that is what is important. They will guide us what is to be done. But in practice, it will be somewhat different from the guidelines. We see different patients apart from the guidelines. We will divide into two categories. Without major comorbidities. Don't say hypertension is there, that is a comorbidity. No. I am very clear about that. All the criteria, I have made it as a concise in the nutshell about all the 4 criteria. We have to divide into without major comorbidities, where you have to have a A1C goal of 7 to 7.5 and fasting pointer is not working, sorry. Range of 117 to 135. So, this is what is required. If it is a frail older adult and those with multi-system involvement, the patient is, as I told you, various disability. Ideally, you can see the target should be 137 to 162, HbA1c 7.6 to 8.5. This is always ideal in any patient. Never bring fasting below 130. That is as per the evidence and various classification and studies have told that this is the target you should follow. These 2 classifications should be borne in mind when you treat a diabetes in elderly. So next one. What's happening? Slide mover. It's our call. So, okay, it is moving now. Next slide is coming. So the next slide is, what does it say is, any patient with comorbids. Working now? Yes. As I told you, this is a very important slide which says when the life expectancy you feel that it is less than 10 years. Some patients you can definitely say it is not even 10 years and there is an advanced age, 8 years or more. The patient is in a nursing home, chronic conditions, varied conditions which can affect his daily living. In those patients, avoid targeting a HbA1c level. That's a simple point. And the first point we always know, minimize symptoms related to hyperglycemia. So to summarize what we learned from an older diabetic individual, the summary is he starts having a cognitive impairment. Along with that, sarcopenia and osteopenia causing bone fragility, sarcopenia causing muscle loss, hypoglycemia is a definite risk, and various complications are there. With this, I will put the most important complication in this patient which can deter all his daily is gastroparesis. He will not feel like eating, he will have GI symptoms, so that he will not be willing to take the medication, or he takes the medication, does not eat food. Proper intake is not there. So we should have all in mind before treating a elderly diabetic. we have discussed this. With this, what is to be done? Sorry. I'm sorry. So no problem. So the next slides contain, yes, okay. What does it say? I'm not going to detail of everything. We have only 4 minutes left. So within 15 minutes, what we could learn is, this slide says, with functional impairment, or the patient does not have a functional impairment. What is the rationale? This is from the guideline, why the target is fixed differently for each functional disability. IADL is when the patient use instrument related active daily living, when the patient is able to use gadgets, not able to use gadgets, that is. So when there are 2 or more IADL impairment, mild to moderate, very complex, living in a residency or a long-term health care, nursing care, all have separate. The rationale is very clear. Significant life expectancy is there in a healthy individual. You target less than 7.5, less than 8.5 is when there is a limited life expectancy. This is for treatment goals. The next slide says, with cognitive dysfunction, very important, with depression, physical disability, polypharmacy. This polypharmacy is always a difficult task to handle in elderly patients. You have to know, apart from the drug for diabetes, what are the other drugs and over-the-counter medication. This is very important, which can have an interaction, drug interaction, and avoid hypoglycemia risk. So that is what is the take home from this slide. The moves from here, it will be easy for us, system. Yes. So this is must know, and we all know that, but what is specific in elderly which can falsely alter HbA1c is when the patient is on hemodialysis, when the patient has anemia of chronic disease. These are the common things that we see in elderly. Anemia of chronic disease due to various chronic inflammation, or the patient has a GI disease, or the patient has some chronic illness, TB or other infections. Polycythemia and others and all, it's for general HbA1c variation. For elderly, what we are worried is hemodialysis, anemia of chronic disease, and whether the patient has a CKD. Uremia and metabolic acidosis can cause carbamylation of hemoglobin, causing falsely elevated HbA1c. So pharmacotherapies, so safe to use as per all the guidelines I have put. I am not going to detail. We will come back when there is time. We will just go to my slide. Yes. So in my practice, what will I prescribe for a elderly individual? That is what is the core of today's discussion. So we have 3 more special situations. They will be discussing about liver disease, kidney disease. Whether I will use sulfonylurea, yes or no. Whether I will use metformin, SGLT2 inhibitors. So whatever I highlighted is ideal for a elderly diabetic. Never use second generation sulfonylurea, especially glibenclamide and glipizide. Not alone for a elderly, even in other situations we have brought down, but in government settings and resource limited settings we are still using glipizide and glibenclamide. I am not saying cannot be used, but cardio safety and other protections for cardiovascular disease is better with a modern sulfonylureas, especially gliclazide. Glimepiride is also a modern sulfonylurea, but it has a higher risk of hypoglycemia compared to gliclazide. Metformin, unless and otherwise contraindicated, it's a wonder molecule. You cannot stop, you can definitely continue. SGLT2 inhibitors, very good, because they have the lowest risk of hypoglycemia. And cardiovascular and renal protection, very good with SGLT2 inhibitors. Second generation basal insulins, what we have in Dclub and Glargine U300, with less incidence of hypoglycemia, especially nocturnal hypoglycemia. It's a very important finding where you can avoid nocturnal hypoglycemia with a second generation basal insulins. Alpha glucosidase glitazones DPP4. DPP4 also has the lowest risk of hypoglycemia. Why I have put in the last is, it has all GI side effects. Already there will be all other gastroparesis and GI side effects in the elderly. Glitazones are very good molecules, especially when there is a risk of sarcopenia. There is a sarcopenia, osteopenia and edema with glitazones. Better avoid glitazones. So thanks Dclub for the opportunity. So any questions I will be willing to answer if there is time. Thank you for the opportunity.
Thank you, sir. If it's all right, we'll take questions at the end of the entire session. Thank you very much, sir, for the informative talk. Up next, we have Dr. V. Mahadevan, who will be sharing from his experience on the management of diabetes in persons with heart disease.
Dr. V. Magavadevan, sir. He is a senior consultant diabetologist and an interventional cardiologist at Kaveri Hospital, Vadapalni. He is also a director at Jayam Diabetes and Heart Specialist Clinic, Virugampakkam, Chennai. As well as he is a director at SPM Hospital, Ashok Nagar, Chennai. He won a Star Award Diabetes in India 2015. Also, he won the Best Doctor Award in Stanley. We welcoming you, sir.
Good afternoon. It's a post-lunch session. It's very difficult to drag the attentions of all the audience. First of all, I would thank the organizing committee as the scientific committee of the Dclub for arranging this wonderful conference and making me a part of this. Special thanks to my Professor Parandaman sir for inviting me. And special thanks to my previous speaker who laid good foundation for me to talk about heart disease. So my topic is, can I get the slides here? The desktop. Both the blood vessels as well as the muscles of the heart. So paving way for both atherosclerotic events, going for acute coronary syndromes, and on the other end, patients may go for a cardiomyopathy. Initially we called as a diabetic cardiomyopathy, now it is called a dilated cardiomyopathy. How you are going to handle these patients? So my topic will be focusing as per, and if you analyze the WHO and International Diabetes Federations, it's very known the impact of diabetes, how it's ruining the healthcare of the mankind. It is one of the most commonest global health threat. Out of the 10 conditions is diabetes. And nearly, if you analyze the censuses by the IDF, nearly 537 million people are suffering from this one form of the disease. And in 2035, another 10 years, it may jump to 592 millions across the globe. And India, the global data clearly point out that this diabetes remains a public health issue, not only to developed or developing countries globally. And the global standardization of diabetes, the prevalence of diabetes is around 6.1. The preventing control, the preventing as well as the preventing the pre-diabetes marching to diabetes and controlling the people not getting into complications is very, very challenging. Many of the people, if you have good diabetes control, the patients may develop some sort of myocardial infarction, acute coronary syndromes, where glycemic variability also plays a major role. Let us focus what is in the Indian scenario. So ICMR in-depth trial that is conducted across Indian populations, they clearly enrolled the prevalence of diabetes is far higher than that of the Western populations. We harbor nearly 11% people are harboring one spectrum of diabetes complications, and pre-diabetes is coming out at 15.3. If we don't intervene or if we don't give much importance at this level of pre-diabetes, these patients are going to jump to diabetes spectrum that is going to become a problem in nutshells. So the main topic is how you are going to interact the diabetes and heart disease. This is a complex link. So how the diabetes is going to develop heart disease, maybe a cardiomyopathy or maybe atherosclerotic events. So as told by Brownwell, cardiovascular disease is a continuum. The patients presenting with acute myocardial infarction, the block is not happening on the day one. the process would have started years, the decades would have happening at the level of the intima media thickness, that is accelerated atherosclerosis. So the risk factors, the continuum starts by the emergence of risk factor. Any diabetic individuals, if you get a hypertension or dyslipidemia, he is more at risk of developing any vascular complications. The atherosclerotics, accelerated atherosclerosis, if they blocks the coronary artery, the patient is going for a myocardial infarction or a spectrum of acute coronary syndromes. If it not been properly treated, the patient is going for a myocardial dysfunctions, maybe of a cardiomyopathy or maybe heart failure or like so on, and ultimately death. So what is the reason for this cardiovascular disease continuum? So we have so much of tools or so much of medications to arrest the progress of this continuum towards the end stage. So if you properly give much importance for diabetes, if you properly give much importance for hypertension, the problem of emerging of acute coronary syndromes can be avoided. In a later point, the patients going for myocardial dysfunction can be prevented. So we have a larger area where you can focus our intervention so that the patient will not go for any form of cardiovascular disease domains. So how the diabetes is going to affect the heart? So what is the pathophysical mechanism? It's a complex pathophysical mechanism, not only a single line. It is a complex pathophysical involving inflammatory molecules. There is a pro-inflammatory cytokines release is there, more of pro-inflammatory molecule milieu is there. There is more release of cytokine, IL-6, so much of things happening. On top of that, lipid getting accumulated due to endothelial dysfunctions paid by the diabetes on the vascular tree. And there's a positive vascular remodeling and oxidative stress. Everything joins to one another. And diabetes itself produces glycation of the products. Glycation of the myocardium, there is stiffness has gone out. The myocardial muscles go for dearrangements. The patients go for heart failure. So when the predominant site of inflammation, the predominant site of pathophysiology is occurring at the vascular tree, we get a patient with myocardial infarctions. So the vascular tree is being affected. The pathophysical defects happen at the level of the myocytes, the patient is going for a heart failure. So these are the things, where the site of the inflammation happening, where the progress of atherosclerosis happiness is a question of times. Patient may present with heart failure or patient may present with acute coronary syndromes. And next in line is many of the medications what we used to treat diabetes give long signal in terms of increased CV events. We can go, if you use thiazolidines, the patients are admitted with the heart failure. Many of the sulfonylureas, older generation sulfonylureas have a red signal that they increase the events of cardiovascular events. So much of controversial happenings. When you analyze the examine trial or save-a-TIMI trial, we get DP4 inhibitors are not good for the heart. Initial trials came on DP4 inhibitors as examine and your save-a-TIMI trial that give a negative signal. This DP4 inhibitors can have a negative impact in terms of increased heart failure. But that was broken by the TICOS trial, which showed the DP4 inhibitors inert molecule is not have any incidence of increased heart failure. So many molecules what we commonly use to diabetes, especially the focus of these molecules is only on the glycemic control. So many patients comes to a clinic with HbA1c of 9 or 10. What the medications you can enroll to reduce HbA1c was our major concern. So many of the molecules we recommended on top of glycemic control may have a negative effect, and few drugs, GLP-1 receptor agonists, SGLT inhibitors give a good signals. So EMPA-REG trial opened the Pandora box. It's a very good molecule in terms of HbA1c control, not only HbA1c control,